Hi, everybody. We are here today for the lecture on Module 5 of Pre-Practicum for the mental status exam. This lecture will take you through exactly what a mental status exam is, when you need to administer one as a mental health counselor, the domains associated with it, and then we'll talk a little bit about the practice you're going to be doing in this week's assignment. So let's start with this guy, Adolf Meyer. Who is Adolf, you say? So he was a Swiss-born psychiatrist who rose to prominence as the first psychiatrist-in-chief of Johns Hopkins Hospital. He was president of the American Psychiatric Association from 1927 to 1928 and was one of the most influential figures in psychiatry in the first half of the 20th century. So what does he have to do with the mental status exam? So in 1918, he developed an outline for a standardized method to evaluate a patient's mental status for psychiatric practice. It combines information gathered from passive observation during the interview with data acquired through direct questioning to determine the patient's mental status at that moment in time. This approach is used to identify, diagnose, and monitor signs and symptoms of mental illness. Each part of the mental status exam is designed to look at a different area of mental function to thoroughly capture the objective and subjective aspects of mental illness. So Adolf was the person that really wanted to standardize what psychiatrists were looking at when they were looking at a patient in terms of symptoms. So before we jump into what a mental status exam entails, the question is, why would you administer one of these? So as a licensed mental health counselor, it is within your scope of practice to administer a mental status exam. You may do this once, you may do this over the course of many sessions. It's also going to depend what kind of setting you're practicing in. So if you're practicing in more of an acute setting, like an inpatient hospital setting, you're probably going to administer an MSE more so than you would, say, in a private practice or an agency setting. So the purpose is to obtain a comprehensive cross-sectional description of the patient's mental state, which when combined with the biographical and historical information of the psychiatric history allows you to make an accurate diagnosis and formulation for treatment planning. So what the heck does that mean? It means that there are domains of mental status, and you're going to look at each of those domains, and then you're going to, as the clinician, think about that, combined with the information that you get in the intake from your counselor or the information that you're getting across time, so biographical and historical information of the history of your counselor, and then you can make a more accurate diagnosis and formulation, and therefore a treatment plan. So when do you administer an MSE? It's generally completed during the first 1 to 2 sessions, and then any other time in reassessing symptoms. Again, it's going to look different depending on which setting that you're in. So when reassessing symptoms, it might include regular intervals of time in order to identify progress or only as needed during the treatment process. You're also going to only administer it if you see symptoms are flaring up, right? So if you have a client that is presenting with bipolar disorder and they're in a manic state and you're noticing from their symptoms that they're in a manic state, that might be a nice time to do an MSE. Or if you have a patient that is presenting as psychotic, that might be a nice time to do an MSE. So again, it's going to depend on where you are and in terms of setting, and then what your client is presenting with. So who administers an MSE? Whose scope of practice is it in? Notice this says trained in front of everything, right? So here's your training that you guys are getting. But you do have to be trained to administer a mental status exam. So nurses, counselors, physicians, psychiatrists, and nurse practitioners are all able to administer a mental status exam. So let's think about it for a second. So the MSE is a method used to document an individual's basic cognitive, emotional, and behavioral functioning at a given point in time. So depending on how the client is presenting, depending on if the client is psychotic or not at that point of time, right? Or think about a client that is struggling with dementia or Alzheimer's, the mental status exam is going to look different at different points of time. It's traditionally been used in psychiatry and clinical psychology, but has also been adapted for other helping professions like social work and counseling, which we're going to use it for. It usually includes a structured interview and a systematic behavioral observation. things to remember. There's significant variability among the forms used by different practitioners to gather this information from a client. So in this module, you're going to learn about 5 different forms to do a mental status exam. There's no one size fits all in terms of what the assessment needs to look like in terms of a form or anything. I want you guys to pick the one that you're the most comfortable with. But the domains are always going to be the same on those forms. So the important points is the mental status exam is just one component of a mental health assessment, right? So just like we would never use one assessment to diagnose or one assessment to figure out what's going on with a client, we want to take all of our information and bring it together. This is just one component of that. Administering a mental status exam is a learned kind of clinical skill, not an innate aptitude, right? You're not like born good at administering a mental status exam. It can feel clunky. It can feel, it can feel out of sorts. It can feel uncomfortable. So the more practice that you get, the better you're going to be able to do that. It requires effort to develop and practice to maintain. So in your assignments this week, you're going to practice administering a mental status exam, but it does feel uncomfortable at first. So it takes some practice to do that. And then it's a blend of empathic, descriptive, phenomenology, I can't even talk today, and empirical clinical observation. So empathy is really, really super important when you administer a mental status exam. And you're going to see that in the examples of the videos that you see this week. And you're also going to use empathy in your assignment this week. So in terms of information, a mental status exam is collected through a combination of direct and indirect means. So you're both observing and asking questions at the same time. It's an unstructured observation. So when you're watching your client, you're watching for things that are in the mental status exam, but you're observing that. You obtain the biographical and social information, and you're asking questions focused about current symptoms. So very, very focused questions. So just some things to think about. As the mental health counselor, and you guys are good at this because you already have, a lot of experience with counseling, but as the mental health counselor, remember when giving any sort of assessment, but especially a mental status exam, you want to have a calming and respectful demeanor. You want to encourage open communication. It's okay to talk through it. You're not just reading your client a list of questions. You want to be very empathic. You want to acknowledge and validate their distress and their concerns. You want to ask open-ended questions, not yes or no questions. You also want the client to explain things in his or her own words. So if you ask them a question, you want more explanation on that. You want to encourage your client to elaborate. You want to avoid interrupting them, right? There should be pacing within your questions. There should be time allowed for silence within your questions. You can guide the interview as necessary, but you want to avoid asking why and instead ask, help me to understand your experience. And then you're going to listen and observe for cues from your client. Also, we want to be conscious of our own assumptions. When we are working with culturally diverse populations of clients, we want to be conscious of our own bias and any sort of assumptions that we're bringing to the table around what normal should look like, right? So things that we think should be true through our lens. And we want to make sure that we're not diagnosing clients or attaching some sort of pathology to clients based on what we think should be normal through our lens as the clinician. Be willing to examine what you think is true and understand that a mental status exam does make assumptions of normal behavior despite cultural considerations. So that's where your clinical wisdom comes into play. You as the clinician are the most important part of the mental status exam because you need to think about your own assumptions, your own bias, your own prejudice, and say, is this client actually within the realm of quote unquote normal or not? So, elements of a mental status exam. Here are the 9 things that you are going to be looking for. you have to remember that the elements of the mental status exam, they're not value judgments, right? You're not placing any sort of value or belief. Again, that's why you have to think through your own lens of bias onto your client. They're descriptors that reflect a client's functioning or insight, right? So if the client comes in, when we look at appearance, if the client comes in and their clothes are dirty and they're poorly groomed or unshaven, right? This tells you something about their typical level of self-care, right? Whether or not it's up to par with what it usually is. It's all information that's coming for you. So here are the elements of a mental status exam: their appearance, their attitude, their behavior, and their social interaction. Their motor activity. So how are they moving in the room with you? Their mood, their affect, their speech, their thought processes and their thought content, their intellectual functioning, and their judgment and insight. And of course, these can feel really subjective, right? So when we talk about things like motor activity, we're talking about the way that the client is moving inside the room in front of you. Are the client's movements jarring? Are they smooth? Is the client catatonic? Is the client, moving all over the place? We want to write down the descriptors of those. Mood is what the client reports about their internal mood state. So what's going on inside of them, especially as concerns any depressive or anxious symptoms. Affect is a client's range of emotional expression based on their speech, facial expressions, or other behaviors. So when the client is talking to you, does their speech, does their facial expression, does it match where they're supposed to be emotionally? Their speech pattern is typically described in terms of fluency, which is the ease or flow, the rate of speech, so from slow to rapid to pressured, the volume of speech from soft to loud, and intonation, so from normal to flat or monotone, as well as any other odd tonality, such as in a foreign accent when they don't have a foreign accent. So that is their speech. Their thought processes are the flow and coherence of thoughts inferred from a client's observable behavior, especially speech. So if you are watching your client and you're listening to them, if the client's speech is rambling and disorganized, you may infer that their thinking is also disorganized, right? So you're making an inference based on the speech of their thoughts based on their speech. Thought content can be inferred from spontaneous speech and direct questioning by the clinician. For example, the clinician might ask, have you ever heard things other people don't hear or see things other people don't see? An answer of yes to such questions raises the possibility of hallucinations or some sort of delusional thought content. Intellectual functioning, right? Is the client cognitively functioning to where they are typically cognitively functioning? And then judgment and insight. Do they understand what's going on? Do they have good insight into what you are saying? So I'm going to click on this, and this will be linked right into your Blackboard as well. So when you're talking about all of these things, there's certain descriptors that you want to use from the mental status exam. So this comes from positive psychology, and these are the common terminology and descriptors that help the write-ups be intelligible to subsequent readers. So just like when we talk about treatment plans down the road or taking notes down the road, we want to make sure that you're communicating in a language that other treatment providers will understand. So when you're talking about level of consciousness, how alert, aware, responsive is the client, right? And your descriptors: alert, hypervigilant, drowsy, lethargic, stuporious, asleep, comatose, confused, fluctuating. All of those things are common descriptors. Orientation: is the client aware of time, space, and nature of the situation? So sometimes in a psych report, you'll see oriented ×3 to time, place, and situation, or partially oriented, right? They understand one of them, but not the other. Their quality of movement: this is their motor activity. This can include gait, fine motor speed, and dexterity. So normal gait, they walk normal, their upper extremities, their arms are moving normally, right? Or unsteady gait, they have tremors when at rest or reaching, slowed movements, or they're restless or fidgety. Their affect, again, is the range of their emotional expression. So normal in range, appropriate to the situation, or blunted or restricted, or labile or very labile, or very variable. right? You want to be able to figure out what's going on with their affect. Their mood is their internal state. So normal, euthymic, sad, dysphoric, hopeless, irritable, worried, anxious, expansive, any of those things that they're reporting to you. The speech, again, you want to look at the fluency, the rate, the volume, and the intonation. So here are all of the descriptors that you can use for that. Their thought process is their free and form of thought as reported by the client or inferred from their behavior or their speech, right? So is their thought process linear? Are they coherent? They're goal-directed? Or is their thought all over the place? Tangential, flight of ideas, loosening of associations, racing thought, thought blocking. And then their thought contact is the nature of their ideas. So is it normal or is it fixed with delusions and hallucinations? Their attention is their ability to focus. Are they attentive or are they distracted? Their memory is their ability to encode, store, and retrieve information. Their insight is the awareness of their own strengths and limitations. And their judgment is understanding how to act and react in social situations, so good, fair, poor. And their motivation effort is their level of motivation towards participating in the session. So did they have good motivation or did they have limited or variable motivation? So what you're going to do is you're going to print this out and you want to use this. You want to use it when you're working with clients, of course, but you want to use it for your assignments this week as well. All right, so here are the 5 forms that I was talking about. So the brief mental status exam form, this is the first one, and you're going to practice with each of these forms. So the brief mental status exam form, and these are fillable, so you can write right in there. You're going to put the client's date, the client's name, the date, and then these you're just going to check off, right? And then if you have any descriptors or anything that you want to of note that you want another reader to understand, you're going to put that in here. So if your client comes in and they're casually dressed, they have normal grooming and hygiene, boop, you're going to check that off. If your client comes in and they're unkept and they're unshaven and their clothes are dirty, then you're going to write that in the other button, box. Attitude, calm and cooperative, boop, then you check it off. If they're not calm and cooperative, then you write what's going on. And you're going to do that all the way down. So you're going to use one of these for each case study this week. So this is the brief mental status exam form. Now we're going to look at the mental status exam behavioral observation form. So again, it's a fill-in. You're going to fill in the client's name, gender. This is a little bit old, outdated in terms of gender. So you can just write in their gender, whatever they identify as, date of birth, age, date of interview. And then this goes into it a little bit more deeply, right? You're going a little bit deeper. So their dress and their grooming, are they neatly dressed and groomed, carelessly dressed and groomed, soiled clothing, and then other descriptors in this domain. And then you go into their motor function. This goes into eye contact and vision and hearing per observation. Verbal comprehension, their orientation to day, time, place, situation, their speech, their affect, how they're reporting their sleep to be, their appetite, their thought processes. So you can see some of these questions are different on each one. The brief mental status exam didn't ask about sleep, but this one asked about sleep. So it's up to you as the clinician. It's very important to know how much your client is sleeping because, again, it leads to diagnosis, which leads to treatment, but you're going to pick which form you like the best. And then this one is the mental status exam and behavioral observation form. So again, it goes even deeper. So client's name, date of birth, age, sex, ethnicity, occupation, living circumstance. So this goes into, it takes all of those big categories and breaks them into subcategories. So their hygiene, their clothing, their physical characteristics, their general behavior and mood, all of their feelings, their perceptions, their thought processes, and so on. So you're going to practice with all 3 of these and then decide which one gives you the most information and which one do you like the best. Then there's 2 more that I thought were really interesting and I thought were really helpful. So I think a lot of times as therapists, we don't take a strength-based approach to our clients. We're really focused on diagnosis and treatment, but we also need to know their protective factors and their strengths. So it's helpful to explore strengths with your clients as well. So after you complete a mental status exam, you can go into this exploring strengths mental status exam as well. So what do you consider to be your greatest strengths, right? And then you write them down. What additional strengths would you like to develop or develop further? You write them down. To what extent are you able to use your strengths in daily life, right? So you've got all of these great things going on, but what is your ability to use them? What, if any, obstacles keep you from using your strengths? And we want to list all of those. What can you do to remove the obstacles to using your strengths in order to reach your goals? So this part is really important because it gives your client agency around those obstacles. Everybody has obstacles in the way, right? But if we can think about what we can do to get past those obstacles to be the best person we can be, your client will have a better prognosis moving forward. And then this last part is mental status exam goal setting. So I really like this. What are your primary goals? And you can list the 3 goals. For each goal stated, list the steps you need to reach it and how long each step might take. So this is really saying, oh, I have this big lofty goal, but let's be a little more realistic. How am I going to get there? And how long is it going to take me to get there? And what am I going to do? And you're going to do that for each goal. Goal 1, goal 2, goal 3. So combined together, the mental status exam gives you, one snapshot in time of what's going on with that client in terms of their symptoms and their presenting issues, and, can move you towards the path of diagnosis and case conceptualization. The exploring strengths and goal setting, I think, really helped you get into the therapy piece as well, because it's just giving you more information on that client, and you can use that information down the road. So a couple more things to think about. Remember, the mental status exam is more than simply a means of gathering information. It's also therapeutic. It's the first contact often that you'll have with your client. That's why empathy is so important, and it sets the stage for your future relationship. So you want to be as empathic as you can be. It also, the first mental status exam with your client serves as a reference point against which all subsequent exams by the same clinician or others will be compared. So it's really important to get as much information and do as much documentation as possible in that first mental status exam. As the clinician, you also need to train yourself so that your examinations are consistent over time and are as objective as possible. This goes back into that bias conversation we had a little bit ago, right? You want to make sure that you are being consistent when you're administering this. You want to make sure that you're keeping your own biases out of the mental status exam. And then just a quick note on using a mental status exam with children. Yes, you can absolutely use a mental status exam with children. It's just going to look a little different, right? So you want to be super welcoming to the child. You always want to allow the parent in the room if that helps to soothe the child. You want to acknowledge and validate the child's concerns just like you would with an adult. You want to encourage the child to explain things in their own terms. You want to look at the child and get all of that observational information. So do they appear well nourished? Are they physically well developed, right? Is their hygiene intact? You want to emphasize open-ended questions and be empathic. You have to be careful with a kid. You want to distinguish between fanciful ideas, imaginary friends, or inner voices that are common in childhood, and delusions or visual or auditory hallucinations, right? You want to make sure that you're not giving a child a diagnosis of some sort of hallucination or delusion, and it's really just a kid being a kid. So that is about it for mental status exams. For your assignments this week, you have 2 assignments in there. The first assignment, you are going to watch 3 different case studies, and you're going to use the 3 different forms: the brief mental status exam, the mental status exam behavioral, and the mental status exam and behavioral observation, 1 for each. Those are all linked in there. And then your second assignment is going to be another video assignment with a client of your choice. You're going to administer one of these 3 again, and then you're going to go into the exploring strengths and goal setting. And right in the assignment itself, it tells you what you will be graded on for that assignment. So if you have any questions, let me know.